it's a great segue, and it's a really important area that we really still have an unmet need in renal cell carcinoma. Today, the standard of care for patients with stage 1, 2, or 3 renal cell carcinoma that's been surgically resected is observation until disease recurs. And there are a number of trials out there and some coming that are looking at both VEGF tyrosine kinase inhibitors, mTOR inhibitors, and even perhaps some of the immune modulatory approaches in patients that are undergoing or have undergone nephrectomy. Bob, do you want to walk us through a couple of trials out there that we should be looking for results in the future?
Yeah, I think the greatest challenge, remember, most patients with kidney cancer undergo surgical resection with careful follow-up. And they're presented with the possibility of risk of recurrence. We've not done a perfect job in trying to predict who's the likely recurring patient versus the one who isn't. When I was at UCLA, we have the UCLA integrated staging system, which has contributed to that. What you're right about is absolutely that the standard of care in surgically resected non-metastatic patients is careful observation. What we're also right is that all trials to date, radiation, IL-2, chemotherapy, vaccines of some sort, have failed to demonstrate an improvement. A recent report at 2013 ASCO by Ari Beldegren, my former colleague at UCLA, called the ARISER trial, based upon some data that we generated almost a decade ago that suggested that one of the downstream effectors of HIF is the expression of something called G250. And G250 is expressed on tumor cells, and an antibody to G250 was developed, and a randomized pivotal trial of antibody to G250 was compared to placebo in high-risk resected renal cell carcinoma, which was unequivocally equivalent and showed no benefit from the treatment cohort. Dr. Beldegren then did some post-hoc analysis suggesting that some expression of G250 on some subsets might predict for those that are more likely to recur, and that's hypothesis generating and certainly worthy of thought going forward. There's also a series of trials in thousands of patients internationally looking at the TKIs, sorafenib, sunitinib, pazopanib. These trials are not yet available for interpretation. Some of them are closed and being followed. Some of them are still accruing. I think the bottom line for the practicing physician is if you have a high-risk resected patient, try and get them on a clinical trial in your community. If you have a high-risk resected patient, understand what the NCCN or other guidelines are in terms of appropriate follow-up, whether they're lymph node negative versus lymph node positive. And for those of us that are interested in trial designs and asking questions, because it's pretty easy to think that the question to be answered in an adjuvant setting is survival, is will any of these immunomodulatory agents be appropriate agents for that question in the adjuvant setting? We hope so, especially if they're tolerated and tolerable. I mean, as many of us around this table know, even the TKIs in the metastatic setting present quality of life challenges for individuals in the adjuvant setting, where the dose, the schedule, and some of the side effects seem to be a bit less tolerated in that space than in the person with metastatic disease that's facing the end of their life.
I think those are great points, a lot of data to bring up, and I think a really important lesson learned from that ARISER study was just how long we have to follow patients to see recurrence. That sometimes it's not that 2 or 3 year window, it's a 5 or 6 year window that this disease is recurring in, and really a different natural history than we used to appreciate.
And when you add to that, that more and more kidney cancer is being found in routine radiographic imaging of the abdomen for some other unrelated reason, the likelihood that we're going to see the true high-risk TNM classification patients, as we did decades ago, is going to decrease, which means that one of the unmet needs is really a profile, a gene expression profile, a biomarker, or some system that would help us identify the high-risk resected patient other than TNM performance status and grade, which is what we produced a decade ago.